So there's a lot of satisfaction in, in being that person who arrives, in someone's worst moment, and just the satisfaction of like helping one person at one time to try to do the best that you can for that. Like in other healthcare positions, nursing and doctors, they have the pay, there's a lot of, there's a large patient load and you don't really get to connect. But being a paramedic and, really only having to deal with like one person at a time, there's the satisfaction of, seeing them directly, and then also like seeing people in their element, seeing them at their homes. You get a really interesting picture of society. I was dispatched to a call for a pediatric asthma attack, and we got there, and the patient had something that is described as silent chest. So silent chest is an issue that occurs in asthmatic patients where, because of their condition, they're moving no air into their lungs whatsoever. It's like being smothered from the inside. The smaller airways in their lungs become, stiffened, or they spasm, so they close shut. So no matter their function of breathing doesn't change, their ability to breathe doesn't change, but because the small airways, close, they're unable to exchange oxygen. So they can take a breath, but the air doesn't go in. Like similar to a vacuum with a clog, okay, where the pump is running, but nothing moves in or out. And so we got there, and it was this 12-year-old girl who was sitting there and just unable to breathe, and it's incredibly painful. And just everything worked that day. So my partner and I were on the same page. We have about 6 different medications that we carry to treat asthmatics, things to open up their airways, to improve their breathing. And we were able to, deliver all those medications quickly. And within, 5 to 10 minutes, this girl has started breathing better, to the point where by the time we brought her to the hospital, the doctor wanted to know why she was there. Because she wasn't really that sick anymore. So that was a really fulfilling day. I've made a difference, and I can count on 2 hands the number of times where I've literally saved a life. But the main thing that I believe the job is providing that comfort, and just being able to make that that small difference in the track. I mean, I could tell stories for days.
Yeah.
Yeah, I went, you asked me before about going into EMS. So after a couple of years, I had gotten really burned out and really, tired of the job, because I got into the job initially to save lives, right? And like I said, the number of times where I've actually made a difference in the outcome of someone's, life or death situation are very sparse. And a lot of the job is, comforting people. And I did, as a young kid, I did not, I've been doing this since I was 19 years old. And I'm 29, so I'm doing it 10 years. Mm-hmm. And when I was a kid, I thought it was going to be all flash and drama. So after a couple of years, I was tired of not making enough money, and not, having that fulfillment. And I left the job and got a job selling cars, selling Fords.
Huh.
Because, I thought, I can talk to people, I'm personable, why not be a salesman?
Yep.
And I lasted 3 days, because we were taking advantage of people, and no matter how much money I was getting, I couldn't do that thing where I was taking from people. Like, people would come in and they could obviously not afford the car that they wanted. But my job was to make the deal, and I couldn't sleep at night, and I didn't, and I realized the thing that I got fulfilled from at work was just being able to make that small difference and lighten the suffering of people, and that was where I was getting my fulfillment from, and I was able to come back and have a whole new outlook. It's interesting because I don't like getting I get really uncomfortable with gratitude. I don't know how to handle it. I had a coworker once tell me that your regular day to day, every single person that you come across, whether you think it's serious or not, they've called because they're experiencing the worst day of their life, and that's helped with because you can get really tired of seeing human suffering, and it hardens you. But I try to keep that in mind as my unique privilege to be that person. Late December was when I saw the first article about this disease that was spreading in China. The big boogeyman is that respiratory illness that is novel. So once I saw that there was this novel virus, once it started to balloon and it had moved to different countries, I started to get really concerned. And then I found out I attended a couple of briefings about it, where they were discussing that there was this spread, and got more alerted to it and more concerned, to the point where I actually came home from one of those briefings, and my dad has a side business where he is involved in like the secondhand ticketing market through like StubHub and Ticketmaster.
Uh-huh.
And I came home and I told him to stop buying a ticket, because I could see the writing on the wall. And then as more details came out about aerosol transmission and airborne transmission, that became a concern. And then once there was a reported case of asymptomatic transmission, that was when I really started, all right, time to get ready, because this is going to be bad. So my first confirmed case, or first seriously suspicious case, was probably 4 or 5 days after that cluster had begun in New Rochelle.
Okay. Yep.
And I had a patient with the fever, cough, gastrointestinal distress, and we were really, we got the call as the person with chest pain, actually. And then when we got there, we weren't wearing any of the masks or anything, because we weren't at that time instructed to wear that level of PPE.
Mm-hmm.
So we got inside and we quickly recognized that this person, had a suspicion, and then, we put on the PPE and everything from a distance. But that was, we walked in and it was, you heard a couple of yeses to it was the first time I'd asked the screening questions and gotten a yes. So, have you been to China? Oh, yes. Have you been near someone who's had coronavirus? Yes. Have you had a fever? Yes. Have you had a cough? Yes. Why didn't you tell anybody? It's always a very skeptical conversation. Why weren't you forthcoming about this to the 911 dispatcher? I would say cluelessness. They just didn't think about it.
Okay.
There a lot of stuff when people know when they have. From my experience, there are certain pains and feelings that cause anxiety and cause people to call 911. So they don't know, recognize this cough, but when they have chest pain, they know, I might be having a heart attack. Let me call 911. So they get really focused on that one symptom, and they don't make the connection between the two. Yeah, I actually, when I knew it was coming, I sat down and I had a little bit of a meditation, and I thought, okay, this is on the way here. Do I want to continue working in the field? Or should I get out and save myself?
Right.
you know, like, because I knew that we weren't prepared, you know, and I knew that it wasn't something that as a paramedic, I was never gonna know, you know, that I knew that my occupational risk was incredibly high, and so I had to think, you know, what did I want to do, and I made a decision that, you know, this was something that I could make a difference in. I guess I like steeled myself and got ready to be like, okay, I might get this, and I actually have to like come face to face with my own mortality, where I was like, you know, I could get this disease, I could die, but I want to still continue working because this is what I do. There was a little bit of like, you know, of this idea like I was young and I'd be okay. You know, I had to convince myself of that, and then I had to convince myself to trust in the PPE. You know, I had to convince myself that the PPE had some offered some level of protection, because I wasn't convinced that it was 100%. 95% of particles that are larger than zero point 0.3 micrometers of the coronavirus is 0. Point like 0.15 micrometers. So it's actually smaller than what the N95 masks are rated for.
Oh.
Yeah. But because it's that, like, the idea is that you need a certain amount of, uh, you need a certain viral load to have an active infection. So even though it's not going to stop all of the viruses, it's going to stop enough of them that you won't get a big enough dose.
Okay.
So like that's the idea behind, you know, putting people in N95 masks. Whether that's the best idea, you know, I don't want to speak on as an expert, but there's more effective PPE. We just don't have enough of it, so we
Yep.
have to deal with what we have and do our best. That's the idea behind what we're using. And so when we go to the homeless shelter, they meet us outside generally, you know, to give us a little bit idea of what's going on with the patient that we're about to go see. So they had actually come out to us and they said, you know, this guy's got a cough and he looks sick. So, and we were suspicious. And then, you know, but they're not medically trained, so they're not really the most reliable.
Mm-hmm.
So we always take what they say with a grain of salt. And then by the time we were like presented with the patient and saw, you know, and they still didn't believe it. Like I still didn't think like this person has coronavirus, because I thought, you know, and then it's only in hindsight after I had seen corona patients that I was like, oh, that guy definitely had it. Yeah, he didn't. He did. I forget. I don't remember exactly. He hadn't traveled to China, but like he had been near somebody who had coronavirus, which is a big, you know, was a big red flag. And you know, he wasn't forthcoming at first. Like he didn't want to tell us because he
Mm-hmm.
didn't think we would take care of him.
Mm-hmm. Mm-hmm.
So then, you know, he didn't. And he like every time he asked the question, he would deflect. He'd be like, "Why are you asking me that?" You know. And then finally, it was some coaxing. So like that also required like some close contact. But that was like the first time I was like, "Oh, you know, that could have been some." I didn't think it was. I was still like skeptical because, you know, there hadn't been that announcement of like, oh, there's coronavirus in New York City.
Mm-hmm. Mm-hmm.
Well, yeah, we transported him to the hospital.
Okay.
Um, but you know, we were wearing N95 masks. We didn't have like the full blown gowns yet, but I was wearing the N95 mask at that, you know, for that call. And then what started to happen was we would go to hospitals to bring, you know, run of the mill patients. And I have, you know, because of all the different, you know, hospitals that we visit on a day to day basis, you develop a relationship with the charge nurses and the triage nurses.
Mm-hmm.
So what started to happen was we would walk into these hospitals, and even though it hadn't been reported in the news, they would tell us, "Oh, we've got," first it was like, "We've got this suspected coronavirus patient," and then it was, "We've got four suspected coronavirus patients," and then it became, very quickly, "We've got three confirmed patients," and we've got seven confirmed patients. They've turned over a floor to dedicate to coronavirus patients. Each day you would come and it would be, more and more, and then all of a sudden it was is nothing but corona. In urban environments in the United States, we already have a significantly overloaded medical system. The hospitals operate at like 98% capacity. So I work a really spread out schedule. I have a large gap of time. So I had this huge gap where on Monday it wasn't being taken seriously by the system overall, and then by the time I came back to work on Friday, it was completely different. So I had, a couple of patients that I suspected in the back of my head had coronavirus, like on that Monday.
Mm-hmm.
And then by the time I came in on Friday, we were being, it was the thick of things. We talk a lot amongst ourselves. We have like group chats and Facebook pages that we communicate on. And yeah, there was definitely like, and I also been doing, the screen, like assisting with that screening,
Mm-hmm.
and the they actually suspended it because the positive rate of the hospital policy changed because there was a 95% positive on a test. Yeah, like the people with the symptoms had it, and with the exposure had it.
So
So
just
they stopped testing for a while
and
because it was, if you had, it became like, if you had the symptoms, you have it. We're not even gonna waste the test. So right, so I get to work, right. So I get to work on Friday, and between, four to six would be like the normal call volume. All right, we get calls. We
Mm-hmm.
don't call them cases. Um, so four to six, and then I get to work on Friday, and I walk in to relieve like we relieve the crew that was before us. So there's two people who are on the ambulance on the shift before us. We come in, and then there's a discussion about like how things are, you know, and so I walk in, and there's a discussion about the amount of PPE that we have, and then there's a discussion about how um, it's the train's gone off the rails. Like, it's
Okay.
nuts. That was already the discussion on that Friday. You know, we're getting hammered. They did 9 calls in 8 hours. So there's that like report from one person to the next. And then so yeah, so then there's a little like warning from my partner and from the other my coworkers of like, this is, wait till you're on the roller coaster, so to speak. Like, it's gonna be a wild ride. I was, I already, I guess, like with doing the screening and doing, having that contact, I had already seen it. So I can't say that I was excited. It was more of like, well, time to go to work.
Okay.
Like there's this mentality of like, of just, do your job. Like, you don't get into the politics of it. Don't get into the motivations behind it. Don't even get into like the disaster at large. It's like you have your part to play, and I play my part. We sign into the system, and generally there's a delay. So we that day we signed on, and within 90 seconds of declaring ourselves in service, we had an assignment, and then another. We got there, and that was that first patient. They had shortness of breath. They had been tested and found positive, um, and they were not doing well. And they were walking, but there's you have these people with incredibly low oxygen levels. So this person had like a SpO2, which is a measurement of the percent of oxygenated hemoglobin on their blood. So it's it's also known as like a pulse ox. So we
Uh-huh.
have a tool that measures like how well your red blood cells are carrying oxygen. And um, this person had it was like 55%, which normally would be unconscious, and they were walking and talking.
Now, do you know
So that
why?
was my first. Yeah, so that's one of the things that's really strange about the coronavirus is that these like low oxygenation levels, um, and that people are not reacting the way that they normally would. I mean, my unprofessional and unknowledgeable opinion, I'm sure it's a measurement failure, because just the way like physiologically it shouldn't happen.
Right, right, right.
That's like my totally unprofessional opinion. Yeah,
He.
this was a gentleman.
Okay.
He was 72 years old with hypertension and diabetes. So he's already in the risk factor. And I went from, not really serious. And then my first patient was like, I don't think this guy's leaving the hospital. And then we finished that one. And then we got dispatched somewhere, you know, 7 miles away, which is a tremendous distance in New York City.
Mm-hmm.
Um, to another same description, and this guy was like 38.
38. And what was the scenario?
So it was we got it as um, shortness of breath, and this gentleman could not talk because he was coughing. He just constantly coughing. Um, so that was already the second patient on a Friday. We administer oxygen, and at that time that's it, because we don't want all the other treatments that we have for like shortness of breath and respiratory illness are considered aerosolizing procedures.
Okay.
So they increase our exposure exponentially. And so we had already, pretty much on suspected COVID patients, we had completely stopped like using any nebulizers or anything like that, so as not to cause any aerosolization. So COVID doesn't cause like a fluid pneumonia, at least not in most patients. It causes that at the end stage. It can cause something called ARDS, which results in fluid in the lungs. But there's actually this and I'm not a pulmonologist, I'm not a physician, so I'm not an authority on the subject, but from what I've read and what I've researched, it actually causes infiltration in the lungs, like the coronavirus infects the actual lung tissue. So the pneumonia comes from the inflammation, not from fluid in the lungs, but it actually comes from the infiltration in the affected lung tissue, causes the pneumonia. So we don't have, normally in pneumonia you'd have changes in a patient's lung sounds. We don't get, their lungs sound clear, they just don't work. At that time, we were still transporting everyone. It hadn't, we work on a system of protocols, like instructions from like from the command, either from the doctors or from our, I guess it's all doctors. So it's either, in New York City, we work under the fire department's like command. So they hadn't yet issued the commands to not transport people. So then we were transporting everyone. But these two guys were sick enough to warrant transport even now under the new protocol. So we would have transported them either way. So that was a big shock because they were they were really sick and different ages. And then I don't really remember the rest of the day. pick out where it was like, oh, these two people definitely have, they were both had already tested positive and had a significant decrease in their condition that warranted hospitalization. So that was remarkable. I wasn't like shocked at it. It was just remarkable to me that like there was still that idea in my head that in order to get really sick you had to be over 65 years old.
Right.
To me it was really incredible that I had someone who was 70 and then my very next patient was 38 and was probably sicker than the guy who was 70. So then what started, the next remarkable thing was, my coworkers started to get sick. I would come into work and it would be a discussion, oh, so-and-so went home, they've got suspected coronavirus. And then it was another one, and it was, another one. So that was probably the next, really significant thing. I had my regular partners, and they were out sick, so I had to work with people who I wasn't as familiar with, which I felt like, increased my risk. Either they weren't taking it seriously, and then the next thing that started to become remarkable was about a week and a half into the social distancing. Two things started to happen. We saw a tremendous uptick in cardiac arrests in the field. Before that, I had a really remarkable call. I went to we got sent to this person's home for an injury, a major injury. Which generally isn't. The major injuries are either they don't have to have paramedics, they can have EMTs, but we got the call, we got there, and it was for a 93-year-old woman who had fallen in the bathroom. We go upstairs to her home, and, we're wearing surgical masks, and when we got there, she was sitting on her couch. Her family had moved her from the bathroom to the couch, and she was complaining of hip pain. So when in women especially, and anyone over 80 years old who suffers a fall, you become really suspicious of either having a broken pelvis or a broken hip. So we assessed her, and one of the hallmark signs of a broken hip is called either external retraction or internal rotation. So what happens when the hip bone breaks, your leg, the muscles in your leg pull the bones together and pulls your leg up. So you'll have one leg that's shorter than the other, and then it turned in one direction or the other. And so we wanted to assess this woman because she couldn't bear weight in the affected leg, and then we saw her, and her leg was, internally rotated and retracted. So there was shortening, so one leg was shorter than the other, and it was turned in one direction, which is like a hallmark sign. Don't need an X-ray. This woman has a broken hip. So we told her that, and she abjectly refused to go to the hospital. She would not go because there was coronavirus at the hospital, and she did not want to get the coronavirus. No matter what we said to her, spent 45 minutes trying to convince her to go because it's not something that would fix itself. It's not. She's not going to get better from her broken hip without medical intervention. She needs surgery or she needs something. Splinting. So that was pretty rough. I walked out of that being like, what's going on here? That this person who has a legitimate medical problem, wouldn't seek treatment. The next shift that I came in was when people started dying. Out of nowhere, we started going to 5 or 6 cardiac arrests in an 8-hour shift. We were talking about before, we'd have 4 total calls,
Mm-hmm.
So we weren't doing those calls anymore. All we were doing was people who had, lost their heartbeat at home. So that was the next big jump. Someone's unconscious, someone's not breathing. Someone, if their family had a little more medical knowledge, they don't have a pulse, they're doing CPR. We get the call. We do get calls where people are for cardiac arrest, where the family members, or the caller recognizes that the person is, dead or is in cardiac arrest. They're not breathing and they don't have a pulse.
And
So we actually get dispatched as a cardiac arrest. So we go in and, we find out that they had a fever and a cough. And, and by then we were already wearing all the PPE every time we got called. But, we walk in and they would have these incredibly high, levels of CO2 in their blood, and they would be in cardiac arrest. We would attempt to bring them back, using all of our medications, and they would be, sometimes you get people in cardiac arrest and they're in, there's a couple of rhythms that you can shock, like the dramatic, television, get the paddles out and
mm-hmm.
give the person electricity, try to shock their heart back.
Uh-huh.
But we didn't find any patients with those shockable rhythms. So these were patients with, no heart movement. And then we spend time trying to bring them back, and, almost futilely. By the time we did 2 or 3 of them, we knew, these people weren't coming back. So we'd actually be pronouncing them dead in their homes and then leaving them there. And then it was just relentless. We would get done with that one, and then we'd have to go and, restart. It's a very resource-intensive thing to try to bring somebody back from the dead. So we'd actually have to, go and restock our equipment each time. And then we'd restock our equipment, and then when we finished restocking our equipment, the very next call would be another cardiac arrest. And so it would be just over and over again, which is something that no one that I worked with had ever experienced. Like that, everyone who talks about this, that's what they talk about, how there was this period of time where every single call was, someone who had passed away. And then there were people who had, we get called and they had been down for a couple of hours. So there we don't even attempt to resuscitate them. So when they've been there for a couple of hours, there are certain signs that are considered signs of obvious death. So they have, rigor mortis is the famous one. Mm-hmm. That occurs after about an hour. Starts in the jaw and then spreads to the rest of the body. And then other signs is something called dependent lividity, where the blood, because the heart's not working, the blood pools in the lowest area. So it looks like people have these massive bruises. Another one is where they have dry mucous membranes, so their mouth is dried out, their eyes are dried out. So those are all considered signs of obvious death. So if we see that, we don't even bother resuscitation. That there's no chance to bring them back. They've been down too long. The process of death has already started, and then you have people who someone saw them collapse or saw them fall unconscious, recognized they didn't have a pulse, immediately started CPR, mm-hmm. and then we take over, and those are the people that we get back. Because, they have that, chain of survival, it's called. The coronavirus, we didn't have much of that at all. So that's what, I guess guided the rules. But now with the coronavirus, because the volume was so high, and because we literally were using medications at a rate, we only have a finite supply of stuff. And like I said before, attempting to resuscitate someone from cardiac arrest is incredibly resource intensive. On any given cardiac arrest, we use, between $2,000 and $10,000 worth of medications and equipment. And that's not billable unless they're resuscitated. So that just, you hemorrhage the money out, which is, another discussion for a different time as well.
Yeah.
But just to give you an idea of how much equipment gets used, it's between $2 and $10,000 every single time we try to attempt to resuscitate somebody. Every single call was cardiac arrest. Every single call was somebody in respiratory or cardiac arrest for a solid week. Where there were still other things mixed in, because there are still regular emergencies that were happening, but the number of cardiac arrests was through the roof. When in a month, I would do 2 or 3 cardiac. A lot of cardiac arrests would be 2 or 3 in a month, and I was doing 3 a day, or 5 a day. I did 5 in one shift. So it's not from the lack of oxygen, that most people are dying, but it's from the later disease process. So we were finding people with other signs of sepsis, which is called which is another name for a widespread infection. Mm-hmm. So they would have incredibly high sugar levels, incredibly high CO2, carbon dioxide, which is a byproduct of living, right? When you breathe in oxygen, you breathe out carbon dioxide. So they'd have incredibly high levels of CO2 in their blood. So we would get these super high readings, that's one of the things that we monitor when we're trying to bring back someone who's in cardiac arrest. And it was just relentless. It was one after another. And then you'd hear other calls going on the radio for cardiac arrest. So I did not successfully save anyone at all. Whether that's because the people were down longer, whether we were so busy that it took more time to get to the people, or people who go into cardiac arrest from coronavirus, there's no bringing them back. It's just the disease has shut their body. It's not they lost blood and now they're in cardiac arrest, or they had a heart attack and that's what their heart stopped. It's the disease has completely shut their body down. So there really wasn't any bringing them back. We tried, but they had. You knew it was futile. So people got really distraught. These are people who are generally in good health. They might have had, some underlying conditions, but they were not sickly. We were doing, and that was the other thing that was remarkable. It wasn't elderly people that we were getting cardiac arrest for. I had cardiac arrest for someone who was a 61-year-old father with 3 children. I did a cardiac arrest for someone who was 41, with kids less than 10 years old. A gentleman who was 37 years old, living at home with his girlfriend who went to cardiac arrest. A friend of mine did a cardiac arrest for someone who was 28. It was no longer fun.
Yeah.
To be at work. I had that moment where I was just relentlessly being punished. Which I think a lot of the people don't recognize, the general public doesn't understand that there was a massive change in what was happening to people. You hear this comparison that really pisses me off about how it's not much worse than the flu. And anytime I hear or say to anyone who says that, I see red and I have to shut them down. Because I've been through plenty of flu seasons, and people don't die in their homes at a staggering rate because of the flu. You can try, but with experience, after a couple of times, you realize that they're not coming back. Right? Yeah, people are not. There's no saving anyone. It's just a relentless Sisyphean feats. People were pretty grateful that we were there trying. I didn't have any experience of anyone that started to wear me down. I didn't really get worn down by the seeing sick people or the increase in call volume, but once it was like so much death, I had not seen that before in my career, and then it became a drag, and then I got sick. So everyone started to fall, one after another. People came down with COVID, and you started to feel like you were in a Pyrrhic system, where everyone's just falling. It was like, have you ever read Catch 22?
Yep.
And the captain, whatever his name, starts to talk about how, you go out and most people don't come back. It started to feel something like that, where like it was just a matter of time till your coin came to turn. I made a joke about even having a tontine amongst my coworkers. They'd all seen Archer, and they were like, "Oh, a tontine," but no one wanted to actually put the money in the pot. So I never stopped being vigilant about about you being safe, and because I knew my goal was to like make it through to the end and be the two guy and pick up all the slack. So I was being really, really careful all the way through. And I just think, in my personal opinion, I just think like, it was, the PPE is not 100% effective, right? It's not 100% guarantee. We work in a really dynamic, in the hospital, it's not a dynamic environment. So you can, these things have to stay tight and they have to stay positioned properly. And we are working in this dynamic environment outside, and there's no way to make sure that your mask stays directly on your face when you're carrying someone downstairs or working in this dynamic environment where you have to, carry them or fight through their apartment that's full of shit, full of like garbage and, and just trying to keep, or like you go into someone's apartment and they're all sick and they're on top of you, and you're in their space, and it hasn't been cleaned, and the virus is just there. So I feel like it's the not 100% effective PPE combined with the dynamic environment. We would go into like a housing project, and you go into the apartment, and there's 3 families living in the apartment, and everyone had COVID. I think I saw a dog with COVID. I'm sitting I was by the door of this apartment talking to one of the patients, and I hear this coughing, and I'm waiting for the really sick person to come out, and this little Shih Tzu walked by, like coughing one by the door. I was like, I think the dog's got coronavirus.
Oh no!
Because they like this like wheezing, like this, like they walked by wheezing. I thought it was a person who was gonna that was gonna be the person I was gonna take to the hospital, and it was the dog. So that was interesting, but that was like common. It was if there was one person who was positive and was sick in the house, we assumed that everybody in the house was also sick. Like that's how contagious it is. The most important thing to like focus on with the coronavirus is that it's novel to the human population. Right? Yep. So if it's in your system, your body does not know how to fight it and does not have any immunity to it whatsoever. So, whether you become symptomatic, we don't know why some people are symptomatic and some people aren't. But it's like a virgin playing field. It's like it's an army that comes in with nobody is fighting against them. They just roll through, because of our gut. Like, and that's one of the best things about America. But liberty comes with liberty comes with a cost of security, right? You know,
I mean,
the
I think about the Chinese system that was one of the things that was really good about it was that when people, I guess in the second week, sometimes it gets very, very bad. And those,
the 10th and 11th, or 10 the 10 between the 10th and the 11th day.
uh, well, those people were in the big, gymnasium hospitals, so they could treat
Hmm.
them right away. Like they knew when it
Right,
happened immediately. Whereas here, I guess it sounds like it happens in people's houses and their family doesn't know what to do.
right, and you know we were really, like, we have a health system that is such operates at a high capacity all the time, you know, and we don't have, like, in China they were able to build these massive hospitals and get them working and functional within like 9 days. We still don't know what patients go to the Javits Center or these field hospitals. Like, it still takes they have to come through the emergency room.
Hmm.
So what I think was happening a lot was there's a lot of fear of people going to the hospital, so they didn't go
Uh,
when they should have. They didn't seek care, and then the people were being, if you there was a like a there's a threshold where you were like almost discharged at the door if you didn't need, the hospitals were so overwhelmed they were sending people who home who weren't sick enough yet.
yeah.
So, and then they would go home, and then they would decompensate, and there's nobody to recognize that was happening. So, I think, unfortunately, our system doesn't work, or doesn't work.
It,
So,
it, Ross, how did your sickness come on? Can you tell me about the sickness and?
oh yeah, well, I forgot we were getting to that. So I was working, and because of all the people who were out, there was a lot of I was working a lot of overtime. I worked about 72 hours in the week before I got sick, and then I was actually at work, and we've been given thermometers to monitor our temperature.
Huh.
So I was taking my temperature every 2 hours, and the first symptom, I didn't have any symptoms, uh, and I spiked a fever while I was at work. So, I had like a, I had an elevated temperature, but not a fever, like of like 99, you know, for the day. And then I'm at work, and I go to take my temperature at the end of a shift, and I had a fever of 101.7, but no other symptoms. So I got in contact with our, occupational health people, and they told me because of my fever, I had to leave work and go home and quarantine for 7 days, regardless of any other symptom. Um, so I didn't go home. I had been put up in a hotel, so I didn't have to cross contaminate with my family.
Mm-hmm.
So I went back to the hotel, and I took a shower and I went to bed. And then I woke up in the morning with explosive diarrhea, no appetite. And then within a couple of hours, I developed a cough. I lost my sense of taste and smell, which was weird. Although with the diarrhea, it was probably a blessing. And then just the combination of the two, and then this cough started to get worse and worse and worse. I started to get body aches and soreness. It became incredibly lethargic. I entirely lost my appetite, where to the point where I did not eat for a week. I had like 200 calories a day. The hotel that I was in, was not. They did not put us up in like the the Ritz-Carlton, just somewhere to be while you were going to work. Like they wasn't for isolation purposes, So my hospital put us up in one of the local like economy hotels, which was was more than sufficient. Now I'm on isolation. I can't leave the room because I can't expose anybody else. And then I had to tough it out by myself in a room for 11 days. I had contact with our occupational health people, and I spoke to a doctor through teleconference every 2 days. So I was monitoring my condition. So it's either like the day 3 or 4 if it's going to be respiratory compromise, or day 10 or 11 if it's going to be something else. The other complications, like the cytokine storm, the ARDS. So I knew that at 3 or 4 days, that was the first like threshold, and I was getting like progressively sicker and sicker. So that was really stressful. And then I started to like taper off, I'd say. So like, I wasn't as sick, or I was, I stopped getting worse. But there was a couple, and then the thing that was, I had heard, and I didn't understand until I experienced it. It gets so much at night. They say like the beast comes at night. So I couldn't physically. I was so sore and in so much pain. It was just finding a comfortable position.
Okay.
And then I would fall asleep. And there was a couple of times I fell asleep in like a bad position, like on my back, and woke up feeling like I could not breathe. I woke up once, and the worst moment of the entire thing, I'd fallen asleep, like, not like for the night. Like I fell asleep for like a nap.
Mm-hmm.
I just passed out, and I passed out on my back. And when I woke up, rather than, normally I would cough, when I took a deep breath. Mm-hmm. But because of my position and waking up, I coughed after I finished exhaling, and I had a coughing fit. So like my lungs had been emptied of air, and then I forced even more air out of them. And I was the one moment where I thought I was gonna die. Because like I could not. I had for like 45 minutes I could not catch my breath, or could not breathe. I could not speak. All I could do was breathe, like try to get air in my lungs. That was probably the scariest moment. I actually called a couple of my coworkers at one point to come check me out. I knew he was at work then, and I asked him to come over and check me out. But I had a panic. That was more of a panic attack because of the shortness of breath.
Sense.
Yeah, it makes you anxious. The worst part was I was alone. There was no one. I was alone in like a hotel room. No one to take care of me. People offered to come, to have me come to them, family members of mine and friends of mine, so that they could take care of me, and I could not in good conscience like go there. I was so terrified. I didn't even want to let the maid into the hotel room to like clean the bathroom because I didn't want to get her infected. And it was just this, like, I felt it was like a personal struggle, or like a marathon I had to run on my own. And then just with the knowledge that I had, my anxiety level went through the roof. Like just everything I'm trying to tell, what's this? Am I getting worse? So just having the knowledge, it made it better, because I didn't like flail about and like seek unnecessary care. I knew that it was pointless to go to the hospital because I wasn't sick enough. I had a fever. Yeah, it was weird because I didn't sweat. I didn't have chills. I would just take my temperature, and the thermometer would say 101, 102, 103. And then I didn't want to take Tylenol because every time I took Tylenol, I felt when the Tylenol wore off, I felt 100 times worse. So I felt like my condition was deteriorating when I took Tylenol. So I didn't take Tylenol. I could have, but I didn't feel much better taking it, and I always felt worse 6 hours later.
Yeah.
That was what I experienced. There's nothing that I can't speak for any medical thing. It's just that for me, like I didn't feel much better. Like I never had like fever symptoms. I didn't have chills. I didn't have, I just had like body soreness and lethargy, which lethargy, which
Mm-hmm.
probably was related to the fever. First day back was last night. It's started to slow down. Where I was doing 7 or 8 calls, I did 2 last night. I mean, part of that is, they brought in people from throughout the country to take some of the volume,
Mm-hmm.
which they were doing before I got sick also. But now the call volume has like fallen down to a normal level. Like we were doing, so the system wide, we did almost 8,000 calls a day for 9 days. And average is just about 4,000. So the call
Wow.
volume doubled for 9 days and then started to taper down. So now we're back to about that 4,000 level. When I was sick, I had like a crisis of faith, so to speak, and felt like, I wasn't sure I wanted to continue, because I never imagined getting sick from what I love to do. I almost felt like I had been betrayed.
Mm-hmm. Mm-hmm.
And so I wasn't sure I wanted to continue. Uh, and then I started to get a little better, and there's a sense of duty that comes with the job, and that came back. So by the time I showed up for work, I was ready to be back at work.